good afternoon, everyone. I'm very delighted to be able to share with you the class standards from an Asian perspective. I know from Emily that all of you attendees are in the helping profession, maybe from Franklin County Public Health or Columbus Public Health, Adam H., Ohio Health, Nationwide, and all of us are healthcare providers, and that is how this information will be presented. I have been doing training for culture, diversity in health for many, many years. It's been my passion, and I've earned expertise in it. I know that we need to continue to understand class standards so that we as individual helping professional is culturally competent. So the objectives for this session are to really understand cultural competency and to accept it as an imperative. It is really not a choice for us. If we are working with population with different cultural, ethnic background, language differences, etc., we need to know that it's important for us individually as well as organization to be culturally competent. So in this webinar, you'll be able to identify the imperatives of cultural competence, which is why should we strive to be culturally competent? And then we'll talk about the changing demographics, the reality that our country has changed, and it has an impact and a relevance to healthcare and how we provide care. We'll talk about the Asian culture itself and some factors, cultural factors, social factors, health beliefs, practices that are important for us to learn so that we can provide culturally sensitive care. And lastly, we'll look at the class standards, and we'll look at some strategies and ways to address these standards with specific examples from an Asian focus. Okay. So the first part will be on cultural competence and why we should be culturally competent. And then the middle part will be, I will integrate the Asian values and what the knowledge that you need to know. And at the end, we'll be looking at the standards itself and going through all these 15 standards using examples of how you can implement. Then we will conclude this webinar at around 3:30, 3:25 with a short checklist that we're going to go through for an action plan to move forward. Okay. So why should we be culturally competent? Okay. I will walk through these four factors that I've identified, and they are the changing demographics, health disparities that continue to exist today, impacting communities of color primarily, with a goal to achieve health equity for all. And also, we need to be culturally competent because it is the right thing to do, and that is social justice. So, because health disparities exist, we know that there are many people who are marginalized, are disproportionately impacted by disparate health care. We also know that the United States has changed in its demographics, and so we will be serving a population that will be very diverse in its cultural background. Okay. And the goal is to have a cultural responsive care that creates higher patient adherence to care improvement in health outcome, and increase in agency morale. And that is achieving health equity. And lastly, for human dignity and social justice, that every individual, the World Health Organization says that the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, no matter their background or identity. So that's for social justice. Let's unpack this. Okay. So it is projected by the year 2050, the majority population, which is Caucasian white at this time, will be 43.6%. And the rest will be communities of color, Okay. When you combine all of this considered minority, they will not be minority or small in number by the year 2050 as projected. Okay. So what is the impact on what we do as healthcare providers? Clearly, the population that we will be serving as we get close to this projected year 2050 will be majority communities of color, of different cultural background, different beliefs and practices. And if we are not culturally competent, then we will not be meeting their needs that are unique to their population. Okay. So nationally, we know that it will change, and actually it has already shifted. Our demographic has already shifted, and you know that from your own practice, from where you work and who you work with. You know that the demographics has changed. And I'm sure some of you, if not most of you, are grappling with understanding the cultural background, because they may be very different from your own belief, your own practices, and it may be a challenge in itself. However, when you understand more about cultural groups and being open to the cultural groups, then we will be able to plan care with the individual who becomes the source of our cultural knowledge. We work with individuals. So as we serve a population that's very diverse, we also need to be open to learning and be sensitive to these cultural differences. Okay. In Ohio, the Asian American community is comprised of more than 345,000 people, which is about 3% of the state's total population. But as you know, in your practice, we have an increasing number of refugees from Asian countries such as Nepal and Bhutan and Burma. So this is increasing now. Now it may be 4% increasing as we have refugees come in. So according to a survey by the US Census, Ohio's Asian population more than doubled since 2000, grew by 66%, and more than quadrupled since 1980. So we have a lot more Asians coming in. So we'll talk about the Asian values and practices, so that we will have a starting point, to have knowledge, to have a starting point to be able to serve this population with sensitivity and with respect. Okay. So more than 24 million Americans of the US population are Asian Americans and Pacific Islanders, which is 7.3%. So in Ohio, the Asian Americans have increased by over 7 million, or 59%. Okay. it's quite dramatic. It's quite dramatic because the Asians has always been a small population in Ohio, but not anymore as we move forward in the next several years. Just an overview of an Asian culture to say that Asian as a group and as a population is very heterogeneous. And I will talk more about this as we move through the slides. We don't have one common language like the Hispanic, for example, have a common language. Other groups have common languages, but not with Asians. And so that in itself can be challenging. And different religions and different history and historical past, different trajectories. So we're not monolithic. We're not one group as long, and to understand one group, then you know it all. No, because I will point out later that there are several subgroups. There's also this myth that you probably have heard, the model minority myth, which is a label placed upon the Asian population that is not necessarily welcome, although in itself it sounds positive and complimentary. Being a model minority for us, Asian, is really not true, because the model minority says or implies that everyone in that population are okay, they are A students, they are of high economic status, they're high education, they're high achievers. All of that may be true, but only for some groups of Asians, not all, just because we are very heterogeneous. You have to look at the Asian population as polarized. Yes, there are those who are very highly educated, very high income, and the data will show that. But that is not true for all groups within the Asian culture. So this is a point that I want you as healthcare providers working with the Asian population to truly grasp that we are not heterogeneous and that the model minority is in fact a myth. It is true for some, but not for all. So Asian Americans, like I said, is increasing in number and rapidly increasing in Ohio. But Asian Americans have actually been a part of the United States tapestry since the 1800s. It's been recorded that there are some Asians who came to California or who came to Louisiana as early as 1800s, but yet Asians are labeled as perpetual foreigner, which is a stereotype. Perpetual foreigner. The question asked is, where are you from? Where are you from? I've been in this country for 53 years. I went to school in New York City, Columbia University. I went to Ohio State University. But still, not so often, but I'm still asked, where are you from? And the next question is, how did you learn to speak English? So even those Asians who were born in this country, who appears Asian, in physical appearance, is Asian, are considered perpetual foreigner. Okay? And it's good to understand this, because you may see this in how your patients, your client, the recipient of your services may respond to you, or may have this experience that's impacting the way they relate to you or to others. Okay? Asians also are an economic force for good. Okay. There's been a recent study in 2023 where they asked 5,000 people what the attitudes are about Asians, and the highest percentage of response was that Asians are hardworking, and they are in the science profession, the math profession, and they serve the community well, uh, contributing to the economy of the country. Okay, and that is true, but not true for all Asians. Okay, so I've stated earlier that Asian Americans and Pacific Islanders are not a monolith, and that the model minority uh, statement or stereotype is in fact a myth. There are several ethnic subgroups, okay, that are considered under the umbrella as Asians. In Central Ohio, we are working with about 16 all of these subgroups. Okay. And I'm not sure if you have worked with a lot of these subgroups or okay, most of these subgroups. So we have Chinese, Asian Indian, Filipino are the top 3 largest Asian subgroups in Central Ohio. And then we have Korea. Was there a comment? And so the other groups are Korean, Burmese, Singaporean, the Hmong, not so many in Central Ohio, Lao, Thai, Vietnamese, Japanese, Malaysian, Cambodian, Bhutanese, Bangladeshi, Pakistani. Okay. This is not all, but these are the most common subgroups you will see in Central Ohio. Now, in perspective, if you want to look at it from, global, and in the map here, you see all of these countries that are considered Asian. Okay. The Philippines and Malaysia, Vietnam, Laos, Thailand, Myanmar, which is now Burma, Bhutan is here, okay. Nepal, India, Pakistan, Sri Lanka, China, Korea, Japan, and Cambodia, just to give a sense of geography there. Let me pause a second here. If there are any questions, feel free to post it in the chat, and Emily will alert me. Okay, and it's okay. I can pause and get back to the presentation. And if there's anything that you would like to contribute as an example or a perspective that you can share, okay, that would be wonderful. I always learn from everyone with a different perspective because we don't have the same experiences, and it really just be enhancing our knowledge and our ability to work with Asians in general. So please do that, and let me go back to my slides here. So the demographic is one reason why we should be culturally competent, right? So I've walked you through that. And then Our goal, basically, to address health disparities is to achieve health equity. You all know about the health disparities that's experienced by communities of color. And you also know that during COVID, these health disparities were just exaggerated or heightened or highlighted because of the isolation, the loss of jobs, and all that has happened to us. Thank God that's behind us now. But the impact of COVID really just increased the issue of health disparities in communities of color. Okay. So we know about all those. And the goal is to eliminate health disparities. Okay. I remember years ago when the language is let us close the gap in health disparities, and it evolved to let us eliminate health disparities. But as we know to this day, that the health disparities continue to exist. We have made progress for sure. We've made progress, but we have not eliminated. We have not eliminated health disparities. But I is on the goal, which is health equity for all. That's where we want to be. That every citizen in this country receive and achieve the highest level of health for all people. Here's a definition of health equity from Healthy People 2020. I'm sure you're all familiar with. So the health equity entails focused societal efforts to address avoidable inequalities, avoidable inequalities by equalizing the conditions for health of all groups, especially for those who have experienced socioeconomic disadvantage or historical injustices. We know that this disparities can be addressed and can be avoided and eventually be eliminated so that we can achieve equity for all groups, regardless of what your background is. For every citizen of this country, okay, deserves health equity, the highest level of health. But we, especially the groups that have been marginalized historically or have experienced socioeconomic disadvantage, that's the group that really we need to pay attention to and address inequalities so that those groups have been left behind and really was not achieving its highest level of health can now experience and achieve health equity. One way of achieving health equity and one way of contributing to achieving this goal is for health professionals, those in the helping profession, those in the service profession, to be culturally competent as individual providers, as well as organizations should be culturally competent by meeting the class standards, which we will be talking about in a few minutes here. So all groups, particularly those who are disadvantaged and have experienced historical injustices, need to achieve equity for all. Okay. We cannot deny historical injustices. We cannot turn our back. We cannot say, well, that has been years ago, and why are we still talking about it? Well, because we know it has an impact on the health of the individual. And if we want to provide care that every individual deserves, particularly the marginalized communities and communities of color, we need to accept that reality and understand what happened historically to certain groups. Only then will we achieve health equity. So our goal is health equity. Equality is not enough. If you look at this photo, okay, equality for these three individuals means you give them equal size box to step on so that they can watch the game. That's equal. You give them the same, right? Equal. But clearly, there's one individual who's taller than the rest. And therefore, not everyone can watch the game. However, equity means that you give them what they need. If it takes two boxes to be able to watch the game, then that's what you give to that group or to that individual, right? So it's not equality. Our goal is equity. Our goal is equity. Apologize for that. Beyond equity, though, we want social justice. Right? We want to achieve social justice. And equity, maybe they can, be able to see the game. But if we tear down the barriers that exist between the population and what they desire, here it is the game, to watch the game, then that is social justice. Social justice is really the right thing to do. It is the right thing to do. And so this is now the imperatives of cultural competence. So I'm just starting with context here. We should all be culturally competent and provide social justice. An important thing also is to look at ourselves, and have an assessment of our thinking about other people, our assumptions about people. Okay, what is our ideas and our attitudes towards people who are different from us. This is very important to be culturally competent. Look at yourself. Ask yourself, while you were growing up, what was it that your parents or the people around you in your environment telling you about people who are different? What were they telling you about Asians who lived across the street, or about Asians in school, the teachers, etc.? What were your assumptions about people? We need to do that. We really need to do some reflection, because everyone thinks that our culture is the best. And that's ethnocentrism. And everyone, intuitively is ethnocentric. I'm the best. But if we are in the service profession, we need to look at the culture of others as different. We're not putting, a value to it. One is not better than the other, but different. And we need to learn that so that we can provide the care that they uniquely need. Okay. There is unconscious prejudice, and I will address that in a minute. Unconscious prejudice impacting the way we relate to people, and some stereotype may be positive, but others are negative. But it, again, is impacting the way we treat people and the way we provide services to those with different cultural backgrounds, such as Asians. Okay. Important concept here that I included is cultural humility. That is an active engagement in reflection and awareness. We need to accept the notion that we don't know it all. Even if we are well-traveled, and even if you had a lot of experiences with different people, we may not know everything about others, the people that we serve. Okay. But with a culture humility attitude, we are open to learn. We're open to learn about the different Asian subgroups that we serve. We're open to learn about the language, not to learn the language, but to be open to know that there are language differences and there are language barriers that we need to address. So cultural humility is really looking at ourselves. And I'm suggesting that every professional provider in the service profession, in the helping profession, in the health profession, that we should be humble, and that cultural humility is a very important characteristic to have or to work on. There is bias and there is unconscious prejudice. Okay. So a bias is prejudice in favor of or against one thing, a person. Okay. Okay. And usually is a way considered to be unfair. Okay. Unconscious bias is when we have the implicit bias. It's not explicit. It's not something that we know of because it's occur in the subconscious. Okay. And implicit bias is really something that you're not aware of. However, your behavior or your decisions or clinical judgment are impacted by implicit bias without even being aware that we are prejudiced or we are biased. Implicit bias doesn't mean that the people are hiding their prejudices. They literally do not know they have them. And some of you might have taken the inventory on implicit bias. And I recommend that to all providers, anyone working with communities of color, population that are different from yours, I suggest that you take that inventory and to find out about your own implicit bias, because you have to bring it up to awareness. When it's in your awareness, then you can choose to change, especially if it's impacting your interaction and relationship with others. Looking at the Asian culture, there are beliefs and practices that we need to understand. Now, what I will be sharing with you are general beliefs and practices. Remember, there are so many different subgroups, different languages. We are heterogeneous. We're not monolith, right? So what I will share with you is general statements. And you as a professional should check with the person that you're helping or the individual that receiving your care to check with them whether what you have heard of or read about or learned about is in fact what they believe, because they may not be believing, what you have learned about the Japanese value different from the Chinese value. But I will be sharing you so that you have a starting point. But these are general statements, and they're not true until you validate it with the individual that you're working with or the family that you're working with. So worldview, important for us to understand the difference between the Eurocentric, which is the white majority Caucasian worldview versus Asians. Okay. For example, for majority white population, time is important. Time is of the essence. For Asians, okay, the worldview is that time is really more circular and ongoing. That's true for other minority groups as well. Other worldviews, okay, other worldviews, individuality versus group. The Asians are very group oriented, they're very relational oriented, whereas the worldview, Eurocentric worldview, is very much individualistic. No, there's no value to this, not good or bad, not, there's no value, it's just different, right? But we need to understand that because when you talk about being on time for the majority population, punctuality is highly valued, whereas other groups, punctuality may not be as important as the relationships, for example. Okay. And again, I'm not saying one is good or bad, one's better and one's less. No, it's just different for us to understand that the worldviews and how people think about the world and perceive the world is different. Illness, perception of illness, definition of disease, different. I'll talk more about that. Language differences, probably the most challenging. I'll talk about that in a little bit. And then the trauma experience. Understand when you have a patient, a client, a recipient of your services from countries where they experience trauma, for example, the refugees or those who were in situations where they were oppressed, or in this late 70s when Vietnamese and Cambodian and Thai and Southeast Asian came to this country and they were considered boat people because they were literally on boats, running for their lives from countries that they were oppressed. So trauma is important for us to look at, especially with the Asian experience of refugees or those from countries that there's oppression of certain group. Stigmatization, shame, and saving face. Okay. This I want to use the example of mental health challenges because there's stigma when one is experiencing mental health challenges, then this is true for all groups. However, let's look at it from the Asian focus and perspective that the stigma in mental illness is more than just a negative connotation, but it is perceived as a shame personally and a shame for the family, because mental illness is believed to be passed on from generation. Therefore, if you have a family member with mental health challenges, then it's perceived as a defect in your lineage, in your genetic, and that's shameful. And so the stigmatization of mental health challenges is greater and is different than the majority. And then generational issues, first generation, second generation, there's always this tension and stress and challenges between the elderly and the children, especially those who are born in this country. Okay. So those are the issues, considerations that you can take note of. So values, respect of elders, family, highly valued. And this is not just for Asians, for other groups as well. But for Asians, being together as a family, consistent with a worldview of groupness and togetherness, is highly valued. So you may have a client who you are getting information from. Maybe a 35-year-old client may say, well, let me just ask my father about this. So a decision making and respect of elderly, their wisdom and their opinions is highly valued. Okay, education is highly valued. Yes, there are a lot of Asians who are highly educated, and this is really what I consider a two-edged sword. We would love to have everyone achieve a high level of education because that is equivalent to productivity and getting a good job and living a better life, etc. However, we have also a lot of Asians who do not have that motivation and drive for education. Okay? But it is generally highly valued. Two-edged sword because on the other hand, it leads you to a better life, better quality of life. But then in the process of emphasizing studying and work to achieve higher education can be very, very stressful. And the literature demonstrated that children, some Asian children, are so pressured to achieve, to be high achiever, that the issue of mental health, depression, anxiety is associated with that. So the other value that you probably that's important to know is that in general Asians want to maintain harmony or balance that being healthy means everything is in balance. Okay, wisdom is appreciated particularly with the elderly. Okay, and also interdependence. Okay, you'll see Asian families in an extended family household. Okay, and from an external perspective, people really see that as not favorable because if your worldview is independence, okay, you see this as dependence. Why would a family stay with other families when they can really have their own household, right? And so they're dependent. But when you label it as such, then there's the negative connotation. Being in extended families, 2, 3 families in a household, why can't you separate and be on your own? But the value here is interdependence. It's not dependency, it's interdependence. When resources are pulled together, for example, childcare, other members of the family will be able to help in childcare, or economically, they pool their resources, and that is interdependence. And I see that James has a hand up, and I stopped to share. Go ahead, James. Go ahead. Do you have a question or a comment? I saw your hand.
Just a comment. You were talking about
Yes,
interdependence, and I've
yes,
noticed that in Asian culture, there seems to be a great deal more respect for the elderly.
true. Very true. And there's also a sense of respect, and there's a sense of obligation to take care of the elderly. Okay. And it's not utopia because a lot of the children, the young, those who are expected to take care of the elderly really are not ready to do that. But that is certainly a cultural value. Thanks for bringing that up, James. Any other question, comments? Thank you. Let me get back to my slides here. So it is respect for elders. It is value of family, honor, loyalty. And again, this is not just Asians, right? But when you're working with the Asian client or family, uh, keep this in mind. That is important. And there's interdependence and not dependence. So causes of disease. We are generally in this healthcare system, we'll look at health and disease from a scientific perspective, medical perspective. So we explain the virus and all of these causes of illness. But one belief system that you will need to take note of in working with Asians are that the disease etiology may be different. It may be, they may explain disease or illness from an upset imbalance. So there's no harmony, there is no balance. That's why you're feeling this way, right? And it may be an emotional or even a physical illness. Upset imbalance. If there's an upset imbalance, what do? Let's restore equilibrium. And there are specific methodology and specific ways of restoring balance. And the disease may also be because your soul left your body, soul loss. Your soul left your body. You could look at it as maybe depression, when the soul, which is the meaning of you, leaves, then it may be depression, but it may be not. But these are just expressions, different expressions of disease etiology and distress. Maybe a spirit possession, maybe a breach of taboo. You did not follow what you're supposed to do in this society. That's why you're experiencing distress and object intrusion. So it's a different way of looking at disease etiology. It doesn't mean that Asians do not believe in the medical scientific explanation, but at the same time, they may be holding on to this explanation of disease. At the same time, they are being treated under the Western scientific medical model. Okay. And also expression of distress, physical distress or emotional distress, okay, is expressed as a frustrated chi, I cannot breathe, I'm exhausted, I have no physical energy, I cannot move my limb. So it is more somatization. So a physical expression for us providers, when we hear this, we need to explore further. What else is going on? Okay. There's been a lot of explanation in the literature about somatization of Asians, but you have to look deeper and see what else is going on. So for treatment issues, look at the language, important, because if you can't speak the same language, right, how can you deal with that? Okay. Lack of awareness of resources, transportation, lack of insurance. Okay. Those are the barriers. Okay. Some practices that you need to know about, complementary and alternative practices, just accept them as a practice and don't put any value to it by saying, well, you know that there is no evidence that this will work. Okay. Unless you know that it is destructive, then really you should be accepting. Exercises, Tai Chi, okay, mindfulness yogas are usually helpful. Let's move on to the class standards. The class standards were developed so that so that we will be able to provide the care, the culturally competent care that minorities and people of color need. So it was published in 2000 and republished in 2013, and there are 15 standards. And they're clustered into 3 themes. But there is a principal standard, okay, that when achieved will really lead to the achievement of all the other 14 standards under theme 1, 2, and 3. Okay. So the first theme is governance, leadership, and workforce. The second theme is communication and language. The third theme is engagement, continuous improvement, and accountability. I'm going to look at the principal standard first and break it down and look at these words that are really important for us to understand. So you need to provide effective, equitable, okay, understandable, and respectful care and services that are responsive to the health belief and practices, preferred languages, health literacy, and other communication needs. We talk about the cultural health beliefs and practices for Asians. So if you want to provide effective, understandable, equitable, respectful, quality care, you need to know the health beliefs and practices. Okay. So this is the overall standard. Standard 2 to 3 refers to governance, leadership, and workforce. Look at your administrators. Look at your leaders, your managers. Are they diverse? Okay. What is the representation of minorities in your governance, in your leadership, as well as workforce? Because standard 2 and 3 and 4 suggest that you need to recruit diverse governance, leadership, and workforce. Okay. And you need to educate and train your workforce so that they are culturally competent and therefore can provide the care that is sensitive and appropriate, language appropriate. Standards 5, 6, 7, and 8 addresses communication, very, very important, because these are mandates. In other words, organizations are required to meet standards 5, 6, 7, and 8. And I hope where you are working, and I know main healthcare systems nationwide, Ohio Health, OSU, they have language services in-house. Okay? Because by law, you have to provide language assistance to those with limited English proficiency. Okay? And you need to inform that it is available, and to ensure that the interpreters and the translators that you're using are trained and are credentialed or certified. It is not acceptable to use children or family members. Standard 8 says that the printed multimedia materials and signage should also be easy to understand. Standards 9 to 15 addresses engagement and community and continuous improvement and accountability. So there should be ongoing assessment of the class-related activities. Look at your own organization and see whether you know who are the champions for cultural competency, whether you know that your organization have enough information to know about a certain population. For example, for Asians, how much do you know? How much data do you have about the health status of Asians in general? Is there an ongoing assessment of how class-related activities are measured, for example. There should be regular assessment of community health assets, needs assessment. I know that's ongoing. And there should also be uh, a way to communicate your organization's progress and how you implement class to the stakeholders, constituents, and the general public. I am personally interested in knowing what does your organization, your system, your agency have or know about the health of Asians. Okay. And so there are stakeholders who are interested in knowing what your organization is doing. So the leadership incorporate cultural competency in your staff evaluation, advertise so that your workforce is very diverse. Make sure that you use interpreters who are trained. It's not acceptable to use children, like I said. You may have bilingual staff and they may have been hired to be bilingual and absolutely used as an interpreter. Okay. I decided to use this picture because this young boy should not be an interpreter, even if he speaks fluent English being born here. That's not acceptable because some sensitive issues really will not be interpreted well if you go through a child. Okay. I want to go to my last slide here. And if you could take it away, Emily, I just want to show you that there is a checklist that you can download, okay, And this is one way for you to look at your own organization. Look at your own organization. There's a fourth slide. The fourth slide, go up. I want you to look at your own organization and use the implementation checklist. Can you bring it up a little higher? There. Here's an example of a question, okay, under governance and leadership. Does your organization have designated class champions? Are you currently implementing this, or are you preparing to implement this, or you're not planning to implement? So this is an example of a very concrete way for you to really assess your own organization. And I encourage you to download this and work it, and this becomes your action plan. And if you believe that it's important to be culturally competent, not only as an individual, but as an organization, do this checklist and share it with somebody in your leadership position, okay? So that our clients who are marginalized from minority population, communities of color, because of their cultural and linguistic background, will receive the care that they deserve. Let me stop at this point and thank you for your attention.
Thank you so much, Dr. Cora Munoz. It has been a pleasure to learn from you today, and we all appreciate your time.